part about playing chicken is knowing when to flinch.
Collision in 400 yards, 350, 300. Captain.
Right full rudder, 30-degree down.
Aye, sir. This one's gonna be close.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
So good afternoon, everyone, and welcome to Sonowars 2014. Yes, we are back, bigger and better even than last year. This year, we have Northern Hemisphere versus Southern Hemisphere, and it's going to be a lot of fun, especially since our Northern Hemisphere colleagues have learnt very quickly the Australian approach called sledging, which I'm sure you're going to see a lot of during the next 90 minutes. We hope to teach and demonstrate in 90 minutes more ultrasound than you would have thought possible. We're going to go fast, and I'll make no apologies for that in advance, but we're going to cover a lot of material. But we need your help. And we need your help because we're going to get you to vote on the educational experience and how good the quality of the images that you've received during the 90 minutes has been. So let's meet our teams. And representing today, the USA, straight it down to the South Pacific, we have Matt Dawson and Mike Mallon. Welcome on stage. It's called staking your claim. All right. But the Southern Hemisphere, the good guys. Who do we have representing them? We have James Rippey and Adrian Goudie. Welcome on stage.
Traveling in a fighter combi on a hippie trailhead full of zombies.
All right.
Let the games begin.
Let's meet our experts. And I mean that in the true sense of the word. So everyone knows Matt Dawson. He's the Director of Emergency Ultrasound at the University of Kentucky. Hands up, please, Matt.
What's that?
And for those who you don't know, the other guy is Mike Mallon, Director of Emergency Ultrasound at the University of Utah. But you know them better as the directors and the producers of the hilarious but extremely informative Ultrasound Podcast, which now goes out to more than 180 countries, if I'm correct in that. So before we start, and we hear a little bit from Matt and Mike, let's find out a little bit about where they're from and why they've left upstairs and come down to us down in Australia. A little bit about Matt and Mike's hometown.
A toast to a new era.
You never took a quarter from a phone booth. You stole. I just got bigger balls than you.
Now, Matt and Mike would like you to think that that's where they come from, but you and I know better. This is really where they come from. Welcome to Australia, boys. Now, representing the Australians, we have Adrian Goudie, and Adrian's an emergency physician at Fremantle Hospital. He is chair of the Ultrasound Subcommittee of ASEM, and of course, he is president of the Australian Society for Ultrasound in Medicine. And the good-looking fellow next to him is James Rippey, emergency physician at Sir Charles Gardner and also at King Edward Memorial Hospital in Perth. We all know James for his passion for ultrasound. And they're also well known because of their contribution to Ultrasound Village and Sono Cave, which I'm sure many of us have looked at. So let's find out a bit about where James and Adrian are from.
build out here.
Honey.
What's that?
We can crack on these guys. They come from that strange country called Western Australia, which is the only country down here making money at the moment, so we can say these things. So before we launch into the competition proper, we might actually put a couple of questions to our experts this afternoon. And my first is actually to Matt and Mike. So if anyone has seen their podcast, which half the world has seen, so I'm sure everyone in the audience has seen, Matt and Mike, you begin every one of your podcasts by saying, if you are not good enough with ultrasound, that's not an excuse to punish your patients with radiation. So with all seriousness, do you think that is a skill that all in critical care should have, being able to do ultrasound?
Yeah.
How much do we pay these guys, Roger, to come down?
No, seriously. I mean, I think that, after teaching ultrasound for a few years now, it's amazing how many docs you see at the end of their career just get so ravenous for it and learn it as well as an intern right out of medical school. I mean, anybody can learn this stuff. There's nothing magical. I mean, if any bloke like Mark can do it, anybody can, right?
What about then to you then, Matt? And also your podcast on Everyone Begins, making horrible doctors decent and good doctors great. Do you think there are some doctors you just can't make decent in ultrasound?
Yeah, I think that's a fair question. I think it's a tough question. Any skill in medicine, there are going to be different levels of proficiency. And so I think everybody can do ultrasound, but at what level, different people are going to come in different places. I mean, all of you are much smarter than Mike, for example. But if somebody who can maybe have failed the second grade 3 times and gets into medical school, it may be a little scary thinking about them taking care of a patient, but even that physician, I think we're going to feel a little bit better if they can do some basic things. Some basic things like guiding a needle into an IJ instead of doing a blind approach. So I think everybody can do it. Obviously there are going to be different levels, but everyone should have a basic proficiency in it.
Right, fair enough. James and Adrian, ultrasound, where is it in WA? And Adrian, with your hat of president, where's ultrasound going in critical care?
Well, it is now considered an essential skill, and so both the College of Intensive Care Medicine and the College of Emergency Medicine have incorporated basic ultrasound scanning, slightly different ones for each college, into their curricula, and as those new curricula are rolled in, it is going to become a compulsory skill for everybody, and I think that's in recognition of the utility of it.
I get really excited about ultrasound, some of you may know, and I think everyone should do some ultrasound. But it's quite interesting, the cardiologists and the obstetricians have got a group of subspecialists who do a lot of ultrasound in those specialties. They can all recognise a heartbeat, but they have subspecialists, and maybe emergency ultrasound is going to go that way. Everyone can do the essential stuff, and there'll be some subspecialists. How does that work at the hospital I work? It works out by making sure about a third of the consultants can do ultrasound to a very high diagnostic level, and the others to an average level. So maybe that's going to happen, but I'm not sure. The bottom line, everyone should do some ultrasound.
Okay, good. Thank you. Right, well, enough from the experts. Let's meet our qualifying team. And thank you again to Philips for supplying the qualifying machines and being so supportive for us. We had even more turnout this year, so thank you. We had 17 attempts at the qualifying station, but there can only be 2 winners. So we're going to meet our qualifying teams now. We have Matt and Pragati, who are going to represent the blue team. Matt, Pragati, do you want to come up on board? And we'll hear a bit about them. And on the white team, we have Tom and Kim. Come on up, guys. So let's find out a little bit about these guys. 2 words or less. Tom.
Yeah, Queenslander, living in Bendigo, full-time beekeeper, part-time emergency registrar.
There are so many ways we could go with that, but we're not going to. Over to you, Kim. Where you work and what are your hobbies?
I'm from Melbourne. I work at the Austin Hospital half-time and Bendigo half-time.
Okay, hobbies?
I play soccer and I look after my trophy wife at home.
Trophy?
Hang on to it.
Not bad. Not bad. Righto. Let's hear from Matt.
My name's Matthew Bourne. I work in a small community hospital in the South Island of New Zealand. It's called Dunstan Hospital. And my hobby is to make sure I do everything my wife tells me to.
And his wife is not standing too far away. Guess where?
I'm Matt's wife, and I also work at Dunstan Hospital, but I'm also a rural GP.
And when we chose the team, we did not know they were husband and wife team. I'm sorry. So this could go anywhere. All right. So these are our qualifiers. They've all got obviously some good ultrasound skills, and they're putty in the hands of our expert, which could be an interesting process, especially for this side of the room. Righto. We're now ready. Introduction's done. James is going to talk us through where we're going with Sonowars 2014.
This is a complex afternoon, and if we actually all get through it in one piece, we'll be doing well. What we're going to do is we're going to have several events. The first is going to be a tour of the body using ultrasound. We're going to have the experts scanning, quick chat about what normal is, and then we're going to do a quiz, asking our contestants to raise their hand when they see the image, which you will see, and tell us what it is. We're going to go right through the body, okay? It's going to be quick. Each section, so ocular, for example, is only 5 minutes. If we don't get through it, we're just going to skip through and go to the next section, because time is important. So the first is a tour of the body and the quiz. The second, the expert teams have both been asked to teach you something. And it's about our teaching. It may be that you don't know what we're teaching you. It may be you're an expert already. But think about the teaching as well as what you're learning. So we're going to teach something. They're going to teach something. Then there's a 2-minute stand up, shake your legs, don't get a DVT. And after that, the expert teams have both been asked in 5 minutes to teach you some procedural ultrasound. So we'll try and do that, 5 minutes each. And the final event is the great race, the relay race, where all of us are involved in a relay, an ultrasound extravaganza, and I'll explain a little bit more about it when we get there. But shall we begin? All right, can we have our models on?
And just before we start, American friends, how are you feeling about your chances right now?
I'll be honest with you, when we first heard about a competition, we were a little skeptical. We thought it was a joke. These two legends of ultrasound, us, a couple punks from the U.S. competing against them. We thought we were joking. So I know what you're doing. You're trying to get us to take some cheap shots at them and get the crowd riled up for their hero Australians. We're not going to do it. We're going to play it completely straight. No cheap shots. I'm not even sure how we would take a cheap shot. These guys, they inspire us. Mike and I were just. How are we going to... They're so inspirational. Mike and I were just talking earlier about how when we get to be that age, we hope we're alive, much less competing. I was really worried about the getting up on the stage, but it was... You guys got right up there.
We'll keep walking.
It's great.
Okay. I like it. How do you respond to that?
You guys?
It's good.
You know the answer?
In their pajamas still, but we'll move on. Okay.
When you know the answer.
All right, so we're going to start with normal scanning, and if we can get
okay, so you guys sit. Yep.
Our initial...
See the screen.
We're going to do live scanning, or we're going to talk about how to scan the eyeball. All right. Adrian, do you want to scan over there? Yep. When I'm scanning an eyeball, I begin looking at the eye with a shallow depth, and I look at the anterior chamber. You put a lot of jelly onto the eye with the eyelids shut. If you're an ophthalmologist, you put some drops in to make it numb, and then you get these big speculum things and you pull the eyelids apart, and then you scan. But you put some gel on the eye and you look at the anterior chamber, and you can measure the depth of the anterior chamber. You can see the cornea, you can see the lens, you can see the entire posterior chamber, you can see the optic nerve, you can see that the cornea is rounded unless you're pushing too hard. So, man, where'd you get these guys? You know, the embarrassing thing, I was saying, so how does this PowerPoint work at the beginning before? So these guys know a lot more about a lot of stuff that would be very useful if I knew about. All right, so anterior chamber, you can see that the cornea is round and the iris flat, and we can see all that very beautifully there. They're pressing really lightly on the skin. You can see the finger on the nose there so you don't push too hard. And in fact, on Adrian's version here, you've got a layer of gel between you, so you're not actually touching the skin at all. So if you've got a ruptured globe, you're not putting any pressure on at all. I have to take a shot, don't I? Oh, you see that? All right. Let's go to... This is going to be fun. Okay, let's get to some pictures now. That's the eyeball. We're going to go to some pictures. Do I need to press forward?
Okay, poor guy.
Do we have a towel? Excellent. All right. Let's get to some abnormal pictures. This is where you guys start, okay? What time are we at?
We're at 1 minute. You're right to go.
Got 1 minute to go?
No, 1.5 minutes to go.
1.5 minutes to go. All right. Can I have some... Okay, here we go. The eye. We're going backwards. We're going forwards. All right, that's my eye. I took that picture by putting my head in a bucket of water. So I didn't have to put that much gel on. That's why that's black there. All right, guys, are you ready? First hand up answers the question. And I'm going to go the wrong way, aren't I? What do you think about this? Okay, blue team.
Is that a dislocated lens?
Okay, it's not a dislocated lens. You can see the anterior chamber here on the one eye and the other eye here. You can look at the angle in there. It's big here, it's small here. Acute angle closure glaucoma. No point. What about this one? Oh, yellow? Yellow? That's my shirt.
That's a retinal detachment.
That is a retinal detachment, and it is a retinal detachment. And a vitreous detachment. They weren't going to get this wrong, was I? Vitreous detachment here. All right, we're going to move straight on. What about this? Go blue.
It's a vitreous hemorrhage.
Good. Very big vitreous hemorrhage. Okay. We're on. Come on. Okay. Try again.
Dislocated lens.
Excellent. And it's got a cataract in it. His vision got better after he got punched in the eye. Quick. Okay, who was first? I didn't see.
Is that a foreign body?
Blue, go on.
Is that a foreign body in the
papilledema. This is the nerve here, little volcano, papilledema. Okay. And foreign bodies are tough, I agree, that's okay. But papilledema, I've given up on measuring the size of the optic nerve. I'm just bad at it, or it doesn't work. The literature's kind of all over the place. We must be about 5 minutes.
10 seconds.
10 seconds, okay. The other thing that we do in those big eyes like that where there's a huge periorbital hematoma are really hard to assess. Here, very gently on, you can see the anterior chamber, the posterior chamber, and in fact you can also, when your slides advance, you can look at the pupil. Shine light in the other eye, you put your probe on there, look down, and you can see that, okay? And that we're just going to skip on through. Your turn, guys.
All right. You sit there just in case this doesn't work. So there's nothing more critical, and this is a critical care conference, than shoulder and elbow ultrasound. So that's what we're going to start off with. I mean, seriously, you're not going to save a life with musculoskeletal ultrasound, but you can maybe look like a rock star with a couple of really simple scans that we're going to teach you right now, and take better care of the patient with this. The shoulder ultrasound, we're not going to cover all the rotator cuff. There's some really interesting literature on point-of-care providers, shoulder surgeons, and how good they get diagnostically, as good as MRI with point-of-care ultrasound. But we're just going to focus on shoulder dislocation, because this is something that is easy enough that you could actually Google one, do one, tweet one when it comes to that. I told you I was going to steal that line and not give you credit.
That's mine.
So, Mike, scan this shoulder. All right, we're going to start laterally. You can see on the screen in just a second, once they split them up there, the humerus in the middle of the screen. Mike's going to adjust his depth a little bit to get a better image of that humerus. He's going to slide up to the humeral head. And then what he's going to do is he's going to slowly rotate backwards until he sees that humeral head. Now Adrian's got a great one over there. I'm switching teams. Damn. And as you move this shoulder, as you rotate it, you can see how it fits right into that joint. Now Mike's got a good one. So he's have the spine of the scapula coming across from the right, the glenoid rim, and the shoulder right in there. So we're going to rotate that around, and you see that's beautifully in joint. We'll look at some picture pathology in a minute. So the other thing we want to teach you, we're going to switch to the linear probe. Elbow ultrasound. You can look at a lot of structures in the elbow, but we really just want to focus on the posterior fat pad. Elbow fractures are tough to see on x-ray, and so we're looking for that posterior fat pad. And somebody had a brilliant idea. Jim Sung and a group at Mount Sinai about a year ago did a study. Can we identify that posterior fat pad with ultrasound? And it turns out we can. It's really easy to see. This is something that you can see on the screen here. Mike has his probe with the probe indicator proximally. So you can see on the screen, is this a pointer works? So you can see on the screen, triceps muscle. This is the humerus right here coming down. And we have the humeral line coming above this fat pad right there. This should be below that line. You can turn 90 degrees as well in the transverse, and you see the two lips of the olecranon in just a minute. So there and there, and you've got a fat pad right here. When you see a big fat pad, it's pretty obvious. The first time I ever read this study at a pediatric shift that night, and a patient came in, suspected fracture. We looked at the study, looked at them, and just did this, and it was very clear. I had a friend of mine that came into the emergency department 2 weeks ago with their kid got kicked by a horse, and said, she's kind of a whiny little kid. I don't think anything's wrong. And so before she even checked in, we took a look at big posterior fat pad. We knew she had a fracture immediately. So, time for the quiz. You guys ready? What is the pathology here? Oh, it's not over here. Okay, now you got it.
It's abnormal.
Great, it's abnormal. Very good. So I'm going to give you a little hint. So here's the spine of the scapula, glenoid rim. Here's the humeral head. Is it sitting nicely in that socket like the images we saw? It's not. So this is anteriorly dislocated. So the probe is posterior here. Here's anterior. And so that's just clunk. It's anteriorly dislocated. Just to show you what normal looked like again, you see that sliding in that socket there, in and out as that video's playing? That's normal. This one was abnormal. All right, and here you actually see a needle coming in. So if you don't want to get warm and cuddly and do a Cunningham technique or something like that, and you need to do a procedure on a patient that you can't get reduced, you could actually, while you have this open joint there, you could stick a needle right in there. Right here, we would just be coming in just underneath this probe indicator. You see the needle coming in. We inject in that joint. 15 minutes later, this was a patient that was sent to us, had been sedated with morphine and Versed. They couldn't get it reduced. They sent it to us. They forgot to send the films. But before we even got the x-ray, we took a look. We saw it was anteriorly dislocated. We put the lidocaine in. 15 minutes later, we reduced it with no trouble. Saved this patient his sedation. And then we can confirm as well. See that it's back in joint. A little old lady who you don't necessarily feel the clunk go back in. You can take a look immediately. You don't have to wait for the x-ray to come and then resedate or do whatever you had just done. So next image. No, not next image. This is just a really interesting video. This is someone who can anteriorly dislocate their shoulder on command. So you can see it popping out there in the distance. I'll play that for you again. So it's in, now it's plunk out. Pretty interesting. So, ready? What's this? Go ahead.
Is it tendinosis?
So this is an unfair question is what it is. You get a still image here, no video, no way for you to really know. What if I told you that the probe is right here on this elbow at 90 degrees, and what do you see here? And what if I tell you that...
Elevated fat pad.
Exactly. So this is the humerus. This is what I was talking about, this big fat pad above this line. That is a fracture there. We know that immediately before any x-rays. Okay, my time's up. But here's some normal images just again of that. You see on the top, the posterior fat pad below the humeral line and below the lips of the olecranon and the big fat pads below. So try this on yourself. You'll see how easy this is to get. And the next time you have a patient with an elbow fracture, take a look and you'll be surprised. And you'll love this, I think, if you do it a few times.
Okay, excellent. Thank you.
Thank you very much. Okay, next we're going to move on to the section of the chest. Now this is a very important section. We're going to talk about lung first, and there's a lot to cover here. So when we're doing lung scanning, what we normally do is we put the probe longitudinally onto the chest, if we can have the ultrasound image up on the screen, so we can identify the ribs, and then we look for the pleural line, because all lung scanning is about the pleural line and the artefacts from there. And so what we can see with James there is the ribs, and we come down to the pleural line, which, if I get the pointer, we can see there. And we basically scan across the entire chest, whatever we can access. We tend to go anterior, superior and inferior, axillary, superior, inferior, posterior, superior if we can get to it, and inferior as well. We look for the lung sliding, we look for other things. Okay, we're going to move on to the quiz section now. So if we can go back to the PowerPoint, thanks. Okay, teams, what's this? Okay, American team, I'll let you have a freebie.
You can actually see a lung point there. You've got sliding and then...
Yep, so we've got lung sliding on one half, not on the other. We see the transition point moving, that is a lung point. Remember, lots of causes for absence of lung sliding, but a lung point means pneumothorax. Okay, here we can see on the CT what the lung point represents. What about even this patient? What do you think you might see in this patient? Yes.
If you roll the patient, it'll stay in the same location.
Very good. So these are difficult patients. They're difficult with ultrasound, they're difficult with X-ray, and sometimes they're even difficult with CT. But yep, one of the important things you can do is roll it. If it's a bulle, it should stay. If it moves, it's likely to be a pneumothorax. If you've got a pneumothorax with adhesions, that gets really tricky, but good point. Okay, this one. Okay, yes?
That's fluid at the base of the lung, and you can see...
Secondly, put your hand up if you know who wants to stick a needle in that. Very good, no one. There's a small effusion there, but looking at the size of it, you haven't got very far to go before you're either going to hit lung or liver. Try and stay away from it, or send it to your nearest friendly American to stick a needle in so they can talk to their lawyers as well. This one, however, who'd stick a needle in that? Fantastic. Lots of space. 2 centimetres to hit fluid, 10, 12, 15 centimetres before you hit lung. Okay, what about this one? Okay, I didn't see who went up first there. Yep.
You've got some
air
bronchograms there, so you've got consolidation in the lung.
Yep, so we see an irregular pleural surface with little air bronchograms through there. Absolutely, that's pneumonia. Sorry, well...
Just point
okay, sorry, we'll just go back one slide. So I'll see if I can get that to run. Oh, sorry. I've just got to go back so that the video will run. So here we have these little bright dots of the air bronchogram. We have an irregular surface up here. Some people talk about it as the shred sign. This is actually the area of consolidation with little air bronchograms and an irregular surface that you can see down here as well. Okay, moving on. Okay, the Australian team.
Interstitial edema.
Yep, so that's interstitial edema, and if we look at the distribution of that, if it follows gravity and there's a nice smooth pleural surface, that's pulmonary edema. What about this one? Okay, yep.
That's an interstitial pattern.
Yep. So
yeah, I'll leave it at that.
Okay, anything additional?
Yeah, so you've got some subpleural sort of collection there. It's a bit of a lumpy pattern.
Retractions, and different from pulmonary edema is the surface is irregular. Is that up here? So as opposed to that previous one. Now, interestingly, the chest X-ray, this was a young lady who had some valvular heart disease, and this was called pulmonary edema, but the ultrasound said that's not pulmonary edema. This was actually her CT. This was influenza A with interstitial pneumonitis. Okay, this one. Okay, a very hesitant hand there.
That's still an interstitial pattern, but it's with the abdominal probe.
Okay, I'm going to stop there. Who can see the ribs on there? Good, no one can, because you can't. Where's the air shadowing coming from? It's here, there's no ribs. The air shadowing is over the top of the ribs. Okay, this is subcutaneous emphysema. Always make sure when you're doing lungs, look for that pleural line. Okay, moving on to the bony skeleton. Yep.
Pneumothorax.
Who said that?
Who said that? I think that was a ventriloquist trick by the Americans.
20 seconds.
Okay, we'll just go through it. Here, this is a rib, and what we can see is there is a little breach in the cortex. That's a rib fracture. We can do the same looking at the sternum. Here's the sternum. We can see the two segments moving. This is a full through and through sternal fracture, which is moving with breathing. Don't forget, though, the sternum is made up of... the ossification centres fuse late, so in adolescence, they don't all have 4 sternal fractures. These are the cartilaginous joints between them and the sternobrae. Okay, and I think that's it.
Stay there, heart.
All right. So let's talk about the heart, the aorta, and the IVC. So let's start off showing some normal cardiac views. Luckily, this is a critical care conference, so they've given me 5 minutes to talk about the heart. It's the same amount of time they gave me for the eye. So, Matt, give me 4 cardiac views, an IVC and an aorta in 30 seconds.
So there's subcostal, get peristernal long right here, peristernal short here. We got an apical 4 right there. Here's your IVC right there. I'm sorry, there's your aorta right there. How many times did you want me to do it in 30 seconds?
7.
Yeah, this is just...
Appreciate that. So,
good enough.
We're actually gonna skip how to do all the cardiac exam stuff because James and Adrian are going to go over that during their little teaching session. They stole that part from us. So instead, if we can just go back to the PowerPoint, we're going to actually look at some quiz questions. All right. So first question here. Oh, I wasn't looking. Hold on, do it again. All right, do it again. Australian team. All right.
Pericardial effusion.
Okay, all right, that's close. Anything else?
With tamponade physiology.
I like it. That's what I'm talking about. So what on this image makes you think there's pericardial tamponade?
Sure, so there's RV collapse and RA collapse as well.
Perfect, yeah. So this is a great example of a subcostal window showing a subcostal four-chamber with collapse of the right ventricle. So you can see there's sort of this little man kind of jumping up and down on that ventricle right there. So it's collapsing with diastole. So this is a great example of somebody who needs pericardiocentesis. How about this one? American team.
Well, you've got a small amount of pericardial effusion around that you can see inferiorly. And it may be something that's chronic because it looks like there's blood.
Yeah, hard to tell if it's chronic or not. The chronicity is maybe not as important as whether there's tamponade or not. Is there tamponade here?
No, because you're not getting that collapse in the ventricle.
It's tough. Yeah, it's tough. So I know what you're going to say. You're going to say yes. Why are you going to say yes?
Oh.
Is it same sort of little man jumping on the trampoline or sort of punching the right atrium?
I like this guy. It's punching the right atrium. That's right. So this is early example. This is early example of tamponade, right? So what happens first before you see the right ventricular collapse is you see the atria collapse, and one of the ways to see that is in your apical four-chamber. So what we're seeing here is the atria is starting to collapse right during systole here. Okay, and I would say this isn't clear tamponade. This is maybe early tamponade. So this is a great example of somebody who's got impending tamponade, somebody you really need to be very careful with because they're about to collapse. And the reason I say that is because if you look at this left ventricle here, it's filling up quite nicely, right? So there's still a good bit of fluid in the left ventricle, still enough volume to come out. Your stroke volume's still decent. You've probably got a decent blood pressure. Not somebody that I'm urgently stabbing with a needle, but somebody that I'm getting prepared to do a pericardiocentesis on. All right, next one. So there's going to be 3 images here. No hands yet. First image. I'll tell you when to go. First image, peristernal long axis. Second image, peristernal short axis. Third image, go. American team.
That's global loss of LV function there, with very minimal contraction.
Perfect. So this is a very low ejection fraction. So this is a heart that's not doing very well, right? One of the easiest ways to tell that is just to look at the mitral valve and see how far it is away from the septum. So during diastole, that mitral valve leaflet should really come up and kiss the septum as blood is going from the left atrium into the left ventricle. It should slap up against the septum, and that's not happening. So for extra points, what is that structure in the right ventricle? What's the structure in the right ventricle?
What's it band, is it? The
Australian team? We're talking about, just to show everybody what we're talking about, what is that right there? Is that an extra ventricle?
Come on, yell it out. Pacing wire. Good. They won.
It was an Australian accent too.
Yeah, well done.
Yeah, I think that's
all right.
ventriloquism.
Next question. Australian team.
So you've got regurgitation of the... What is it, Kim? Which chamber is that?
Let's not worry about the color so much. American team.
You've got a pleural effusion.
And
you've got leakage through the mitral valve.
Okay, so there is a pleural effusion. You're right on that one. There's also a pericardial effusion. So if you look at this image, this is a great image because it shows both a pericardial and a pleural effusion at the same time. And you can tell the difference between the two. The pericardial effusion here is tracking in between the aorta and the heart, right? And then you have your pericardium, is this white line right there. And then the pleural effusion is back behind it. So a nice way to tell the difference is a pleural effusion is going to sort of sit behind the aorta, whereas a pericardial effusion is going to get this bird's beak appearance and sort of try to skirt in between the heart and the descending thoracic aorta. How are we doing on time?
Yeah, it's about time.
10 seconds.
10 seconds. All right. So next, what is this? Go. 5, 4. Yep.
Is that hokum you got?
Yeah, perfect. That's hokum. So big septum right there. Really interesting image. All right. So let's keep going. Low IVC here. And then here we have a pretty interesting image of an aortic dissection. All right.
Okay, cool. All right. Good work. We're sort of keeping to time.
So who's ahead so far, James? Can we have a show of hands? Who's the American team ahead? Hands up. Sorry, boys. Australian team ahead.
Oh, they're all shy. You're allowed to vote twice, we've decided. Okay? My 6-year-old said to me on Sunday, will you come play Lego with me, Daddy? And I was busy writing this talk. And I went, I'd love to, but I'm really busy. And he looked at me and said, you know, when you die, all this work you do won't mean anything. Oh no, what do you say to Osler about that? You know, trying to make a difference. So I went and made this gallbladder Lego heart with him. A little bit about gallbladder ultrasound, better if you're fasted. We're looking for a hypoechoic, fluid-filled saccular structure in the right upper quadrant. But other bits get in the way. You have to sometimes look through the ribs, look subcostally all over the place. You want a nice longitudinal view, which we're starting to see stuff here. Here's a gallbladder. Might change the depth. Now, these guys had lunch, you see, but that's the life of an emergency physician. They've always just eaten. So here's a gallbladder, nice thin wall. You measure the wall against the liver. Nice work, Adrian, Goudie.
Okay. Breathe away.
We're running out of time. No, they're so variable. You're going to change patients. It's not a problem. We're going to go on. There's confidence. So we're looking for a gallbladder, but after that, we look to see if there's obstruction. So we're looking at the gallbladder for the wall, for any bright things inside it. But then, when you're looking for obstruction,
with a cholecystectomy?
Yeah. Well, he's got no kidneys either. He just wait. Bilateral orchidectomy. We're doing well, you know. You're just waiting for that now, aren't you? All right. Then we look at the liver for intrahepatic duct dilation. So we fan up and down through the liver. You can do that. That's that big sort of homogeneous organ in the top right-hand side of it. You look at the CBD, but let's get to some cases. What do you guys think? All right. Go for it, Aussie man.
Cholecystitis, thickened gallbladder wall.
Okay. Postprandial gallbladder, normal. All right. Contracted, sorry. Maybe it is, no. No, it's so contracted gallbladder, slightly thickened wall. Go for it. No.
Well, this is a gallbladder.
He does that. Does he always
does it
do
all
that?
the time. It's got stones in it.
It's got stones in it. Yes. Okay. Oh no, that's bad. That's not us.
Bad.
Good. Stones, shadows, stones in the gallbladder. All right. What about this one? Okay, go for it. It is you.
There's another gallstone in there as well, you can see.
Okay. Anything else?
And it's very thickened gallbladder wall.
Okay, so cholecystitis, we're looking for a thickened gallbladder wall, we're looking for sludge or pus in there. Here there's a stone stuck in the neck, we're looking for fluid around the gallbladder, we're looking for hyperemia, you're looking for sonographic Murphy's. Sore when you push. Good work. These are polyps, they're not shadowing. I'm going to go on. We don't have enough time for this. What do you reckon about this? Yeah, go for it.
There's some peri-gallbladder edema. This is probably acute cholecystitis. I can't see any gallstones. Maybe it's acalculous.
Okay, so we've got a really thick gallbladder wall. What are you guys experts? Mike, what do you reckon?
Thick gallbladder wall. Lots of things can cause that. Any inflammation in the abdomen can do it. The positive Big Mac sign. So if somebody had a Big Mac on their way in to get their abdominal pain checked out.
Or Vegemite.
And,
or positive Vegemite sign.
Oh yeah, the positive Vegemite sign can do it too. That's true. So ascites can do it sometimes.
Yep.
You can also get things like infiltration to the gallbladder wall by cholesterol, stuff like that.
Yeah, so lots of things cause it. The most common thing is inflammation around there. So this lady had acute hepatitis, but I've seen it with pancreatitis and pyelonephritis, but low albumin states. Lots of things cause a thickened gallbladder wall. Makes it tricky. What about this one? Teams? Normal? Abnormal? Okay, we have an answer.
There's a calculus right at the bottom there at the neck.
Excellent. Around the corner. All right. Big stone there blocking it off. That's not going to fall out by itself. Needs a surgeon. It's hard, isn't it? Okay, what about this one? Normal? Geez, gallbladders are hard sometimes, aren't they? They're getting harder. Okay, we got something. I'm going to give you a hand before you say anything. Okay? Because you were brave enough to put your hand up, I'm going to show you the transverse view of the same thing. All right.
That's a gallbladder that's filled with an amorphous material.
Excellent. So sometimes the gallbladder gets full of grey stuff. And this is inspissated bile in a cystic fibrosis patient. Grey stuff can be blood or pus or bile, all sorts of stuff, and it makes looking for them really hard. Time? How long?
10 seconds.
Okay. All right, I'm going to tell you. Sorry. This is a gallbladder full of stones with lots of shadowing behind. And you can't see anything behind it. Really easy to miss, because this is bowel gas, this is the gallbladder. Tough, isn't it? Grey shadow versus black shadow. This is an acute cholecystitis. It's not anechoic. It's all grey and pussy and horrible. End of that bit. Good work, guys.
All right, so let's talk a bit about abdominal ultrasound. So we'll talk a bit about the small bowel, the appendix, and the kidneys. So, Matt, how do you go about scanning the abdomen for, say, the appendix?
So for the appendix, sometimes I'll start with the abdominal probe, sometimes the linear, depending on the patient. To be honest, the first thing I usually do on a patient like this is ask them where it hurts the most, hand them the probe, and actually let them put it exactly where it hurts the most.
Perfect, and that'll actually get you the appendix about 30 to 40% of the time, and it's perfect if you're not comfortable with your anatomy, like Matt. So the other thing you can do is you can actually try to find the cecum. So you can have the patient, first off, take their right leg and cross it over their left leg. That's going to pull their psoas anterior and help push the appendix so it's a little bit more visible, right? So now we have this structure here. Matt, go ahead and show me the cecum if you can. So just kind of take the probe, put it in the right lower quadrant, and have the probe marker up towards his head. And all you're looking for is air. Just about the only thing you see on ultrasound is air. Now, once you find the cecum, you can move a little bit more medially, and the cecum's almost always full of air. And once you move medially, you should start to see the psoas and the iliac vessels. A lot of the times, you'll see the appendix kind of draping over the iliac vessels. And right here, we have Matt showing me the iliac vessels here. There's an iliac artery, iliac vein. This is the psoas right here sitting right next to them. And then Adrian had a good view of the cecum there. That was the air from the cecum. You see the air. It's got that kind of gray shadow coming down from it. So this is where we're looking for the appendix. Really uncommon to see a normal appendix. Pretty challenging. So what about small bowel obstruction, Matt? How do you go about that?
Kind of wave the probe all around their belly like this, looking for dilated loops of bowel. Very scientific.
Yeah, it's kind of like it's abdominal massage, really, is what you're giving the patient. So the one thing you want to think about is that air, when someone is supine, if they've got air fluid levels, the air is going to come anterior. So if you really want to see fluid-filled bowel, you really have to go sort of lateral and almost posterior. So kind of the paracolic gutter sort of region is where you often have to look for the small bowel obstruction. Real quick, just show me a kidney. I just want to see a normal kidney. Can you do that? Good. Perfect. So here's what we see when we see a normal kidney. Typically, we're looking for any hydronephrosis inside the calyces here. And then go ahead and show me the bladder. Adrian's quick to the punch. Bladder right here, clearly. We look at the UVJ for any stones. So now let's take you through a couple of the slides and do some quizzes of some abnormal things that we can see in the abdomen. So if we can just pull the slides back up. All right, guys. So what is this? Australian team.
Appendicitis.
Correct, that is an appendicitis. What is the normal size of the appendix? Less than what?
Depends on the race in the patients. Vary from...
What?
Look at
Not that one. Variable.
Less than 6 millimeters is the normal size for the appendix. Greater than 6 millimeters, we're starting to think about appendicitis. Blind, ended, tubular structure, non-compressible, typically full of fluid. You shouldn't see air inside of it. That's what an abnormal appendix looks like. Knowing all those things, what's that? Yeah, it's acute appendicitis. Perfect. So where would you measure this one? If you were going to measure this appendix, where would you put your calipers? Perfect. Here. So laser pointer. Come up here. Where would you measure that appendix? Ooh, oh, that's aggressive. There you go. Yep. Close. You wouldn't go anywhere near there. You would start anterior. No. You would start anterior. You want to start anterior, posterior, and you actually go from the outer black line to the outer black line because that outer layer of appendiceal tissue is hypoechoic. So you actually need to go from outer black to outer black. So many people measure that inner line, and that's the inner lumen of the appendix. So you're actually underestimating things if you do that. How about this question? I'll give you an extra one. What is that right around the appendix here? What's all that? Yeah, that's inflamed fat, right? That's the thing you see, like the periappendiceal inflammation on CT scan, right? Pretty interesting. All right, so let's go to this next one here. We've got pretty psoas, iliac vessels, clear appendicitis. This is the appendix tracking up. I'll just continue to tell you guys all of this fun stuff. Bam, appendix attaching to cecum right here. That's actually the cecum sort of bulb coming out right here. What is this structure right there?
Point on their screen.
Is our fecalith?
Yeah, perfect. Spinnacolith. Great. All right.
30
keep going.
seconds.
What is this?
Small bowel obstruction.
Perfect. So greater than 2.5 centimeters in dilation, back and forth peristalsis, multiple loops of fluid-filled bowel. This is actually a stomach putting in the NG for that patient who had the bowel obstruction. This is called the poop waterfall sign. So this is you'll see this sometimes when patients have left lower quadrant pain, come in with diarrhea, you take a look at their left lower quadrant with ultrasound. This is a dilated and thickened sigmoid colon. You can see it both in short axis and long axis. And then of course you can look at the kidneys for hydronephrosis. This is an example of moderate hydronephrosis in a patient who has a stone right here in the actual ureter. You can see the stone and the shadowing right behind it, right there. And then here's another example of hydronephrosis. This is a patient who had a stone at the UVJ. You can actually see the shadowing coming down. One great trick when you're looking for stones at the UVJ is to actually put color on the area. And you get this twinkling artifact from the stone. We don't really know what causes it, but for one reason or another, the stone itself will twinkle, and sometimes you even see twinkling coming down from the stone. And a lot of the times, you can actually improve your ability to see the stones, then turn the color off, measure the stone, you know how big of a stone there is at the UVJ. Bam, you're done.
Okay, next we're going to move on to the reproductive organs. So, when we're scanning, we'll go to the... Right, so we start off and we do longitudinal. Yeah, we thought we'd give the Americans a handicap for this section. So, find the bladder and then find the uterus longitudinally. Okay, then we turn transverse and we'll sweep up, and we make sure we sweep all the way through the uterus, left to right, and then top to bottom, so we're covering the entire organ. And that way we also know anything that we do see, we know whether it's inside or outside the uterus. Otherwise it's very easy to focus on something, zoom in on so quickly that you actually lose exactly where it is. Okay, we'll move to the PowerPoint slides, thanks. All right. So, we're up there.
You didn't want us to do testicle?
Not yet. We'll wait. Depends, how much did we pay him? Okay, so if we can have PowerPoint slides, thanks.
We've got them on there.
We've got them on there. If we have them up on the screen, thanks.
Press the forward button.
No.
That's the one.
That's the one, thanks. Right, teams, what's this? Yes?
An intrauterine pregnancy.
Okay, yep, it's an intrauterine pregnancy, and if you look very carefully, you can see the little heartbeat, so that's a live intrauterine pregnancy. Okay, next, what's this?
Is it a fibroid?
No. Anyone else? Yes?
There's a uterus there.
Yes. Definite.
You can't see an intrauterine pregnancy.
Okay, but what we can see is a little sac-like structure. Okay, this is actually a pseudo-sac. It looks very similar to a gestational sac. You're not allowed to call it a gestational sac unless you see a yolk sac or an embryo inside of it. Okay? What's this? Yes?
It's an intrauterine. There's a gestational sac.
Yep, it's a gestational sac and there is a pregnancy. But I'm going to show you the next loop, which is of the same patient. This is the uterus with a pseudo-sac. And those are of the same patient. As we sweep through, we can see the uterus coming through with the pseudo-sac. And then as we come across, we can see the pregnancy. It's outside the uterus. But as I said, if you go straight on that and zoom in, then you won't actually notice it's not inside the uterus. So that's a live ectopic pregnancy. Okay, what's this one? Yes?
That's fluid outside in the pouch of Douglas.
Yeah, we put the FF on for the Americans. So, okay. Yep. Okay. Left ovary, young lady with pain. Okay, I think we're probably... How are we going for time?
30 seconds.
Okay, so this is an ovarian cyst with some hemorrhage in it. We can see the blood clot sitting down there.
Goes
Moving
straight
on to the
last
testes, we won't do it. So this is a hyperemic testis. It could be orchitis. Now this one, there's two images here. This is sweeping from top to bottom. This is a guy with sudden onset pain. And if we look here, we put the blood flow on, low flow on the scale, so we're not missing anything, but even with that, there is no flow. If we go back to this one, and I'll just quickly point out, as we sweep through, if you look up here, you can actually see there's the twist in the spermatic cord of the torsion, okay, as it runs through. You can see it twisting. Okay.
I saw this last slide.
Sorry.
I just wanted to ask Matt and Mike what they thought about this. This was someone I scanned the other day, and they had a little epididymal cyst. And inside it, if you look very carefully, this is the testis. You can see sperm swimming around, it looks like, in there. This is. I saw that. I don't understand that. Sperm are they're smaller than a red blood cell in diameter and a bit longer, but what do you guys reckon?
I think that's pretty common. In the U.S., the sperm sometimes are so big we keep them for pets. So it's definitely sperm.
I like that. There is something called the filarial dance with Wucheria bancrofti. You can scan dilated loops of lymphatic vessels in the testis, and you see what looks like that. So he should be checked for that. But for all my life, that looks like sperm to me.
Filarial dance. Wow. Now I've heard it all. Not sure your brain can take any more of Sono education, and I've got to go feed my pets. So we'll see you in a week with part 2.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.